Hello, thank you for having me here today. My name is Carrie Pilarski, and I'm a rehabilitation psychologist at the University of Michigan. I serve as the chief psychologist for the spinal cord injury and complex medical rehabilitation units. I also provide outpatient services and help facilitate the Michigan Medicine Spinal Cord Injury Virtual Peer Support Group. My roles with disability advocacy have included work within the American Psychological Association Committee on Disability Issues in Psychology, serving a term from 2013 to 2015, and then again more recently in 2020. Within the APA Division of Rehabilitation Psychology, I helped to establish and co-chair a special interest group of psychologists with disabilities, which is currently the Disability Identity Committee. I serve as vice chair on the executive board for our local Center for Independent Living. And lastly, I proudly identify as having a physical disability. And if you would meet me in person, you would see that I utilize a power scooter for mobility in the community. It is this background that brings me here today to talk about spinal cord injury, clinical care, and advocating for disability justice during a pandemic. My goals are to discuss some of the unique considerations for individuals with spinal cord injury and their care, identify ways to adjust care to meet physical and mental health needs during a pandemic, and then lastly, identify action steps for advocacy and supporting disability justice. I'm going to break the unique considerations down into a few categories. First is general care. Early in the pandemic, services were reduced across the board to essential services and care needs so that people could isolate and stay home to limit contact. For individuals with spinal cord injuries, reductions in routine care could have been even more challenging, as they may often have received care on a more regular basis. Furthermore, reductions in limited access to personal protective equipment, medical supplies, and medications were experienced by many, but compared to the general population, those with spinal cord injuries may be more likely to need these supplies and therefore were disproportionately affected. Reductions in access to caregivers or home care services further impacted those with spinal cord injuries. And all of these things combined likely increased fear in seeking services that were available or even basic needs. There's also increased vulnerability for those with disabilities or spinal cord injuries, whether they resided in an institutional setting or at home. They were unable to self-isolate, maintain the 6 feet distance between them and others, and sometimes even difficulty wearing a mask because of their disability, as well as their needs to have more contact for their healthcare and having people in and out and increased contact with others. The risks associated for those with spinal cord injuries, if they contracted COVID-19, were also much greater because oftentimes they were already immunocompromised, had greater risks associated with respiratory infections, and may have had complications with missed or delayed diagnoses for reasons that their spinal cord injury may have masked or hidden those concerns. If they had problems with temperature regulation or respiratory problems, missing symptoms of fevers or cough that were early warning signs of needing to be tested for COVID-19. Acute care services and inpatient rehabilitation were also impacted. Hospitals were overrun and there was bed shortages, ultimately needing to use some of the rehab services to help with those acute medical needs. And so the result could be shorter inpatient rehabilitation admissions, limited visitors and people being allowed at the hospital, reduced family or caregiver training, certainly reduced peer contact as already discussed by Tom. Therapists were limited and unable to provide home evaluations. And then ultimately, patients discharged home with fewer follow-up services and increased isolation, all of these things resulting in a compounding stress and a negative impact on physical and mental health. So in order to think about some of the adjustments that were needed, it was gradually that some routine care services were able to be reestablished. And in that process, a combination of determining services that needed to be in person versus those that could be done virtually took place so that people could start to receive the care they needed. In terms of inpatient rehabilitation, many adjustments were made that included virtual services. Initially, rehabilitation psychology services were provided via telephone or using a tablet with the support of rehab engineering to set up those technology services and help connect the provider with the patient. Virtual services were included for the educational group, to include family and training, and also to connect patients with peer supports. Similarly, on the outpatient level, physical, mental health services and peer supports resumed in many ways, utilizing virtual platforms. In terms of COVID care, much needed to be learned, and oftentimes advocacy for the needs of individuals with disabilities if they needed to go to the hospital to receive COVID care. Many of our acute therapists were called to serve in the COVID care capacity. And there was a lot that was learned by including physical medicine and rehabilitation providers, physicians, and psychologists to address the needs of those experiencing the difficulties with isolation and needing to maintain their physical health while receiving COVID care. There were some pros and cons with many of these virtual transitions. Many services did not need to resume in person, which was a positive, and many could reach broader audiences. So our support groups were now able to be received by people that wouldn't normally be able to travel to our local area, which was definitely a positive. But there's also many drawbacks of not having actual contact with people, and that many existing health inequities were exacerbated. So that individuals who didn't have good use of technology, access to technology, or connectivity were further isolated and limited in their services. I worked along with several others, Erin Andrews, Kara Ayers, Kathleen Brown, and Dana Dunn, to write an article titled "No Body is Expendable: Medical Rationing and Disability Justice During the COVID-19 Pandemic." And this article highlighted concerns with medical rationing and medical discrimination. Medical rationing is the allocation of scarce resources, which necessarily entails holding potential beneficial treatments from some individuals because there is not enough supply to go around. Medical discrimination takes place when there's discrimination in the provision of healthcare, which is based on disability or even perceived quality of life, and so that it's disproportionately affecting some people. Early in the pandemic, crisis care standards and triage protocols emerged that were expressly biased against disabled people. It included things like recommendations to reallocate ventilators from current users to meet the acute need for ventilators. And many of these identified discriminations had to be addressed. The Office of Health and Human Services opened investigations and warned against possible violations of the Americans with Disabilities Act. Disability activists and medical ethicists had to advocate for crisis triage protocols that did not unfairly disadvantage disabled people. Some of the recommendations included things like focusing on near-term prognosis rather than subjective assessments of longer-term prognosis or subjective determinations of quality of life. Furthermore, encouraging healthcare facilities to make sure to adopt a transparent process to reduce bias in decision-making procedures and processes. It's also very important to recognize that advocacy should not fall only on the individual with a disability or their support system. Healthcare professionals must advocate in their communities and in their healthcare systems. Just a few ways to advocate and things to think about include making sure to advocate for accessible education, communication, and sharing of information so that there are sign language interpreters, closed captioning. It is written in a way that is understandable. Also making sure that testing and vaccination sites are accessible. Another way to advocate took place throughout the pandemic, where advocating for use of virtual options and coverage for virtual services, initially supported through crisis policies, but needing to be maintained and continues to be an area of advocacy. And another last area I'll point out is making sure to coordinate interdisciplinary care and services at every level of care, beginning in the emergency department, for those who understand disability, such as providers in physical medicine and rehabilitation, to be involved at every level of care. Those are just a few areas for advocacy. There are certainly many others. I leave us today with this picture, this artwork created by Alicia Marie, representing concerns with caregiver support and recognizing it as a crisis and a means to help support advocacy. So I leave you with this and hope that we'll continue to have a discussion during this panel, the next panel presentation. Thank you.